Okay, the next section of your text deals with the vagina. Recall that the vagina is a fibromuscular canal that leads to the cervix, and the first of the disorders that we want to talk about is adenosis. However, before we can understand adenosis, we need a little bit of background, and so I'm going to take you to the whiteboard. Again, the vagina is a fibromuscular canal, and this fibromuscular canal is lined by surface epithelium, and it so happens that the surface epithelium of this canal is stratified squamous epithelium that is non-keratinizing. And so what I'm drawing here, each of these boxes represents a squamous cell that together is forming this stratified squamous epithelium that again is non-keratinizing. Now this is the normal lining of the vaginal canal. However, if we go back to embryology, recall that the vaginal canal is actually derived from two different things. The lower 1/3 of the vaginal canal is derived from something called the urogenital sinus, and the upper 2/3 of the vaginal canal is derived from something called the Mullerian duct. Now remember that the Mullerian duct is the source of the female reproductive system. So for example, the uterus is derived from the Mullerian duct, the tubes are derived from the Mullerian duct, the cervix is derived from the Mullerian duct, and the upper 2/3 of the vagina is also derived from the Mullerian duct. Now let's go back down to this lower 1/3 urogenital sinus. The cells that line the urogenital sinus are normally stratified squamous epithelium. However, the cells that line the upper 2/3 that was derived from the Mullerian duct in utero is columnar. And so what happens during development is that the stratified squamous epithelium from the lower 1/3 begins to extend during development again, all the way up to eventually replace the entire vaginal canal, so that these columnar cells should disappear and be replaced by squamous cells. If there is a disruption of this process and the columnar cells persist, then the presence of persistent columnar epithelium in the vaginal canal is called adenosis. And that's what I've mentioned here in your text. So adenosis is focal persistence of columnar epithelium in the upper vagina, because of course the upper vagina is derived from the Mullerian duct. Now this can rarely happen in a normal individual. However, the key association is that adenosis is seen with increased incidence in females that are exposed to a drug called DES in utero, or females that were, I should say, exposed to a drug called DES in utero. Now DES, we need a little bit of a pharmacology tie-in here. So DES actually stands for diethylstilbestrol, and it is a estrogen-like compound that was developed in the late 1930s. It was initially used to treat symptoms of postmenopause, but over time it gained popularity for prevention of pregnancy-related complications. So for example, women who had miscarriage or who had preterm labor would be given this drug while they were pregnant. Eventually we learned that this drug crossed the placenta, and when it crossed the placenta it would cause disruption of uterine development, and one of the things that it would disrupt was the conversion of columnar epithelium to squamous epithelium in the vaginal canal. So again, remember that the lower 1/3, which was derived from the urogenital sinus, was squamous, and the upper 2/3, which was derived from the Mullerian duct, was columnar. And these squamous cells would go up and would normally replace the columnar cells. However, DES would block this process, and women who were exposed to DES in utero when this process was occurring in fetal life would eventually not have this process occur properly, and so they would have residual columnar cells, and the presence of those residual columnar cells was called adenosis. Here's an example of a patient with adenosis. Essentially, I'm drawing the basement membrane here, and everything to the left of this basement membrane is stratified squamous epithelium, and here represents the canal. So essentially, everything to the left is normal. Now, in this particular woman, as the squamous cells came up and replaced, the other thing that should have happened is that the columnar cells that were present deep underneath the epithelium, within the canal itself, should also have been resorbed. And in this particular case, which these cells again here that I'm circling should have been resorbed. However, in this particular case, these cells are not resorbed, and so you have persistence of columnar epithelium in the upper 2/3 of the vaginal canal. Now, you wouldn't know that this is the upper 2/3, I'd have to tell you that, but in the upper 2/3 of the vaginal canal, and so it's this persistence of columnar epithelium that again refers to adenosis, and this picture is actually taken from a woman who was exposed to DES in utero. Now, adenosis wouldn't be that big of an issue, but the key problem is that adenosis can lead to another complication, which is called clear cell adenocarcinoma. Carcinoma, of course, refers to a malignant proliferation of cells. Adeno refers to the fact that those cells are forming glands, and clear cell tells us that they have a clear cytoplasm. And so essentially the complication of adenosis is that women could develop later on in life clear cell adenocarcinoma. And this is a rare complication of DES-associated vaginal adenosis. Now, it was the discovery of clear cell adenocarcinoma, along with other complications, that eventually led to the cessation of DES usage. And ever since about the late 1970s, we no longer use this drug. I'd like to briefly just talk about some of these other complications because it is important to know. And so let's just kind of review the patient populations that could be exposed to DES. So the first patient population that could be exposed would be a DES mom. So this is a mother who was pregnant, let's say in the 60s, and she had some preterm labor, and so she was exposed to DES. Now, if DES mom was carrying a girl, then the drug would cross to placenta, and she would produce a DES daughter. And if a DES mom was carrying a boy, then the drug would cross to placenta, and it would produce a DES son. So these are kind of the key populations that could be exposed to DES. Now, DES daughters, the key first complication, which we've already discussed, is that they could get vaginal adenosis. And the problem with adenosis is that adenosis could potentially become something called clear cell adenocarcinoma, which was the feared complication of exposure to DES. Another thing that could happen in a DES daughter is that there could be abnormalities of just the formation of the uterus and the tubes, in particular the smooth muscle of the uterus and the tubes. And so they would get abnormalities in the formation of the uterus in relation to the tubes, and this could lead to an increased risk of ectopic pregnancy, infertility, or pregnancy loss, so pregnancy and gestational type problems. So those are the two major complications that would arise in DES daughters. Now, DES sons, fortunately, they have no significant complications. DES moms, the one key complication that I would point out is that DES moms, or mothers who were exposed to DES when they were pregnant, have a slightly increased risk for breast carcinoma. And that shouldn't be hard to remember because DES essentially was an estrogen-derived compound. And breast carcinoma is something that is related to estrogen exposure, and so it's not hard to associate the exposure of an estrogen-like compound with a cancer that's related to exposure to estrogen. And so those are the key patient populations that would be exposed to DES, and those are the key complications. And it's the learning of all of this that led to the cessation, again, of the use of the drug, and it's no longer in use. The second disorder that we want to talk about is something called embryonal rhabdomyosarcoma. Sarcoma refers to a malignant mesenchymal proliferation, and rhabdomyo refers to a cell that has features of skeletal muscle. And so this is a malignant proliferation of immature skeletal muscle. It's relatively rare. I highly doubt you'll ever see one in your practice. However, those things that are rare in practice are often common on exams, and so it's important to be aware of this disorder. Now, this disorder has a very interesting presentation that you need to be aware of, and that is that this disorder often presents with bleeding and a grape-like mass, which is arising from the vagina, if it's a female, or the penis, if it's a male. And it classically occurs in a child less than 5 years of age. Because this produces this grape-like mass, it's also called sarcoma botrytis, and botrytis refers to grape-like mass, or it's a term that literally means grape-like mass. Here's a picture of the grape-like mass, and all I'm showing you here is the mass. I'm not showing you, obviously, the protrusion of the mass from the vagina or the penis, but essentially you notice all these grape-like bubbles or grape-like protrusions here, and so they call this sarcoma botrytis, again, because of this grape-like mass, and it also, of course, represents an embryonal rhabdomyosarcoma. Now, they don't usually show this picture on exams, but they often show a picture of a 5-year-old girl, which is the classic picture, and they show this mass protruding from the vagina, and so that would be the classic presentation. Embryonal rhabdomyosarcoma has a key cell, which forms the tumor, and that cell is called a rhabdomyoblast. The rhabdomyo, again, refers to skeletal muscle, and the blast refers to the fact that it is an immature cell. So rhabdomyosarcoma is actually defined by the presence of rhabdomyoblasts, and that's an important take-home here. Now, a couple of features of the rhabdomyoblast that we should be aware of. The first is that rhabdomyoblast will often show cytoplasmic cross-striation. So when you look at a rhabdomyoblast and you look at the cytoplasm, you'll often see these cross-striations running up and down the cytoplasm, similar to what you would see in skeletal muscle. And so if I were to tell you, for example, that there is a child and they have a tumor and the pathologist says that the tumor exhibits cytoplasmic cross-striations, you're going to think about a rhabdomyoblast and in turn a rhabdomyosarcoma. Another way by which we can define the rhabdomyoblast, or maybe I should say identify the rhabdomyoblast, is to use something called immunohistochemistry. Now we can stain for certain antigens present in the cell, which would then help us to identify the cell. And two of the key antigens that are helpful in identifying a rhabdomyoblast are desmin and myogenin. Desmin, again, is the intermediate filament that is present in muscle cells. And so if we know that a cell is positive for desmin, we know that it is a muscle cell. And myogenin is a nuclear transcription factor that would be present in immature skeletal muscle. And so if the tumor is positive for desmin and myogenin, that would automatically tell us that we're dealing with muscle that is immature skeletal muscle. And of course, because it's producing a mass or a tumor, that would indicate a rhabdomyosarcoma. And so these are some important features of rhabdomyosarcoma that we should be aware of. The final disorder that we're going to talk about is vaginal carcinoma. Vaginal carcinoma is a carcinoma that arises from the squamous epithelium that lines the vaginal mucosa. I've already told you that the entire vaginal mucosa is lined by squamous epithelium. This tumor is classically related to high-risk HPV, so you're thinking about HPV 16, 18, 31, and 33. And the precursor lesion for this is dysplasia, which again is called a vaginal intraepithelial neoplasia, also called the VAIN, and that again is the dysplastic precursor from high-risk HPV, which eventually becomes vaginal carcinoma. Now, one important thing to note is that patients who get vaginal carcinoma that eventually invades and spreads will get spread to regional lymph nodes, as, again, carcinomas generally go to regional lymph nodes. But what you need to know, and what's particularly high yield here, is that because the vagina is derived from two different sources, depending on where the cancer is, the spread will be to two different sets of lymph nodes. So recall again that the vagina, the lower 1/3, is derived from something called the urogenital sinus, and so cancers that arise from the lower 1/3 will actually spread to the inguinal nodes. Recall again that the upper 2/3 of the vagina is derived from the Mullerian duct, and so cancers from the upper 2/3 will actually spread to the regional iliac nodes. And this is again particularly high yield because it's a nice way that examiners can go back to basic anatomy and test you on relationship of embryology and basic anatomy to clinically relevant issues related to cancer. And that concludes the section on vagina. Again, a lot of important principles that are derived from some important tie-ins, and hopefully you'll be able to paste all that together.